Welcome back. This is episode 33 of the MedEdit podcast, your ultimate resource for evidence-based medical education.
And the only podcast where two board-certified physicians interview specialists addressing topics the listeners request.
In this episode of the MedEdit podcast, we are revisiting the topic of mental health. If you remember, way back in episode 11, we addressed peripartum mood disorders, which included postpartum anxiety and depression. Then in episode 13, we discussed the benefits of psychotherapy with a professional counselor. It is now time we take a moment to discuss fact versus fiction with mental health care pharmacotherapy, otherwise known as medication options.
Don't miss the second half of today's episode where we have a celebrity hype segment again. You know, the tragic death of legendary actor Gene Hackman and his wife, which has been in the news for months. But what do we actually know about Hantavirus, which ended up being the cause of death for his wife? This is a medical school throwback, as we do not see this diagnosis very often, thankfully, hence why it deserves a minute for discussion on the podcast today.
This episode is packed, so get ready.
We are your hosts, Dr. Cari Sorrell
and Dr. Jessica Gray. Welcome to the MedEdit podcast.
Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the MedEdit podcast.
All right, and I'll just throw in a caveat for anybody watching today. I apologize for I guess if you know who that is, Theo Von podcast style today, but we have some eye swelling that's pretty extreme, so this is the best option. So if you're watching on YouTube, just know this is not if this is your only episode you watch, this is not the usual.
Cari looks really fashionable today with the big sunglasses and the hat. I think it brings some real life to this episode.
Absolutely. Yeah. I may look a little Looney Tunes at the moment. So I just want to throw that out there in case this is the only episode somebody's watched so far. When it comes to mental health, society continues to lack really the necessary support systems we need. Everybody knows that. Healthcare, not healthcare. There's still way too much stigma associated with seeking help. We don't have enough physicians who are well-versed in managing mental health care as well. Television and media gives medications really a bad rap. Really, today's goal is break down the most common medication used to treat conditions such as depression and anxiety and separate some of the fact from fiction.
So let's start with how we treat anxiety and depression. And we'll focus a little bit on the anxiety portion because I think that there is a very big misnomer when it talks about medications related there. When we're talking about anxiety in this scenario, we're talking about generalized anxiety disorder. This relates to that overwhelming anxiety feeling affecting activities of daily life. This isn't an isolated anxiety that happens when you get on an airplane or when you are getting an MRI. This is the kind of anxiety that makes you feel like you're in a pot on the stove and you're just about to simmer and something's just going to trigger, you're going to hit and boil over all that anxiety. There's a certain character on the HBO show White Lotus who has a whole episode devoted to her love of a certain benzodiazepine drug, lorazepam. So we thought we could give a little shout out to the hair. This drug the character is referring to in the TV show works on the same receptors in the brain that alcohol acts on. So imagine being at work and your coworker has to pause a stressful meeting to take a shot of vodka before jumping right back in. You would be a little concerned, right? That's probably not, so you might check on him or her. The role that benzodiazepine drugs plays is very specific. We don't use it for these one-off occurrences of feeling anxious or these everyday occurrences of like, I'm just feeling overwhelmed. I need to go take a lorazepam, like our character says. There is a role for them and what we use them for, but that's not what is recommended to do for generalized anxiety disorder.
Absolutely. And, they do end up a lot in media and they end up a lot, I would say even pop culture, like you said, like that's most common one that's really referenced or that class of medicine. So I feel a lot of people are most familiar with it, but they say we're not going to use benzos. Really, what medication do we need to be using or do we use for generalized anxiety disorder?
So we use a class of non-addictive, non-habit-forming medications to treat generalized anxiety disorder and depression, but we're just focused on anxiety right now. They're called selective serotonin reuptake inhibitors, or SSRIs for short. These include things like citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, and sertraline. And if you hear all those words and you don't recognize any of them, those are all the actual generic names for very common ones that you know and are familiar with things like Prozac and Zoloft, Lexapro, Celexa, Luvox. Those are the brand names. So we'll refer to all the generics here, though. So SSRIs are classified as antidepressants, which oftentimes my patients tell me, but I'm not depressed. I don't need that. And I tell them, yes, I understand that may not be the primary feeling you may be, complaining of. But lucky for us, this class of medications actually treats both anxiety and depression. In fact, SSRIs are indicated for anxiety disorders like we're talking about, but also eating disorders, menstrual hot flashes, obsessive compulsive disorders, post-traumatic stress disorder, premature ejaculation in men, premenstrual dysphoric disorders, and some other somatic symptom disorders. So we use them actually for a variety of reasons.
Absolutely. I definitely have recommended those more than a few times in my practice and get the same response. With irritable bowel syndrome, we've seen a huge benefit with that. And people are always like, but you're just saying that I'm crazy and that's why I have symptoms. And I have to try to explain to them that there is a connection though between our brain and our gut. And sometimes we have to modify that connection to treat symptoms.
Absolutely. And then prior to prescribing an SSRI, your clinician, so your physician, your advanced practice provider, nurse practitioner, whoever is prescribing it, does need to talk to you about side effects, time to response, drug interactions, and then, of course, what happens when we want to stop the medicine. So clinicians should review common side effects and the need to take the medication as prescribed rather than on an as-needed basis. And I think that's one thing that patients always, say is like, I don't want to take something every day. And so I kind of try to tell them that, good things take time. Things like this, where it doesn't act on that same brain receptor that alcohol does, they actually, it needs time to build up in the system. And so just kind of having that roller coaster of I take a pill and I feel, I'm anxious, I take a pill, I come down and I'm less anxious. Well, then it comes building back up and it rebounds. And this up and down roller coaster effect is actually a lot worse on the body than doing one of these SSRIs that you take daily and just kind of lowers the level, right? So that you don't go from 0 to 100 all of a sudden. You may be able to go from like 0 to, 15, 20 and then be like, okay, hold on. My logical thinking is going to kick back in there. So, really what we want to do is do this so that the SSRIs can work on that chemical in your brain, that serotonin that your brain actually makes naturally. And it just helps it leave around more. It doesn't actually help it make more. It helps it actually just kind of leave a little extra around and not recycle it or get rid of that extra floating there, which helps a lot. So patients just really need to understand that although some improvement in your mood may occur within the first 2 weeks of taking the medication every day, it might actually take up to 8 weeks to reach the full clinical effect. Patience and medication compliance, so taking it as directed, is key here.
Absolutely. And it's also important for patients to know there are some potential drug-drug interactions, especially if other drugs also increase the amount of serotonin in the body. So if you are a patient, make sure to discuss all medications with your prescriber. There's also a risk of something called serotonin syndrome, which can be dangerous if too many drugs are combined, increasing serotonin levels in the body.
On that same note, it's important to understand that abrupt stopping of your SSRI may precipitate adverse effects such as dysphoria, dizziness, GI upset, which can include nausea, vomiting, diarrhea, fatigue, chills, myalgias, which are like muscle aches, headaches. Is it going to kill you? No, but you may feel really crummy. And sometimes the only way to get that feeling is kind of almost to come off it for a little while or restart the medicine for just a short period of time. But as a caveat, everyone can come off of the medication. Nothing you take here is going to become addictive and your body can't get off of it. We just tell you, hey, we're going to cut it in half for 2 weeks and then maybe take it every other day. Depending on which one you're on, we may do a slower taper or not. So it just depends. But just that being said, I don't want it to scare off anyone. They say, oh my gosh, if I stop it now, I'm going to be sick forever. No, not at all. It's just that you stop something suddenly, there's a chance you might have some negative side effects. Temporarily.
Temporarily, yeah. And overall, they are pretty well tolerated and extremely effective. So that's the important thing. In fact, several of these medications have been studied closely in pregnant patients without, adverse effects on the baby, which is also really important because that can be a period where anxiety and depression can be heightened. And a lot of people are scared to take medications. There are also several approved for use in children and adolescents when your clinician deems it appropriate. As we mentioned previously, many patients experience improvement in mood, usually within 1 to 2 weeks, while others may require several more weeks of treatment, like you mentioned, up to 8 to 12 even.
Yeah, so it takes a little while. I always just remind my patients again, good things take time, right? It's not that shot of vodka that's going to make you feel a little better for temporarily. This doesn't dull your brain, especially if you're on the right dosage. A lot of patients will say, well, I've heard, especially in some pop songs and things, about feeling numb, right? So if you're feeling numb on your medication, you're either on the wrong medication or your dosage isn't correct. So let's just caveat there. So if you are actually on the correct medication regimen, you should not have those symptoms. But the reason that you do take it once a day is because the half-life of the drug in the system averages about 24 hours for most of these, with the exception of the medication called fluvoxamine, which is taken in divided doses when the daily dose is actually more than 100 milligrams. So that one's just a little special. Usually we advise patients to take the SSRI medication in the morning to minimize the potential for insomnia, although there's actually no real evidence that insomnia itself is related to the dose timing. So if you feel drowsy on the medicine by taking in the morning, just switch to bedtime, and that can actually help a lot with those symptoms.
Absolutely. And, talking about helping with some of the symptoms or side effects, a fun fact that sertraline is actually the only SSRI that is absorbed better when it's taken with food, but the rest can be taken with food that may minimize some of those GI symptoms like nausea we talked about.
Yeah, which I think that's super cool. That I was like, oh, that one actually is better with food. But so we always start with the lowest minimal effective dose to avoid side effects. I know we said side effects a lot, so we're kind of going to discuss those because those are one of the biggest barriers to people starting is the worry about side effects. In my patients who we suspect they might be sensitive to medication side effects in general, we often start them on a subtherapeutic dose for a few days and then increase the dose to the minimum therapeutic dose. So for example, I tell them to take half a tablet for the first 4 to 5 days, then increase to the full tablet once they're tolerating it well. Finding a patient's perfect dose is a process of trial and error due to everyone's metabolic makeup being different. If tolerating side effects well, we will usually recommend a 4-week trial at that minimum dose. So it's not like you start it and then, okay, a couple days later, I amp it up if I'm not feeling 100% better. We say about 4 weeks before adjusting the dose or adding any additional treatment options. Slow and steady wins the race here. After that, we can usually increase the dose every 1 to 4 weeks depending on the response and tolerability.
All right, Jess, but what about some of those genetic tests that are advertised for psychiatric drugs?
So yeah, there's a couple ones that we can do. Some of them are cheek swab ones and some of them are blood tests, and they do some genetic testing that tells you how well you metabolize certain psychiatric drugs. This is kind of an emerging new field in this area. It's been around for a little bit now. I've had it in my clinic for a little while, but rarely use it. And I think that's kind of what the most evidence out there says is that these genotype testings, they are looking at certain polymorphisms. They're available to guide you in choosing a specific SSRI medicine and then the dosing of the drug. But currently the tests are really not standard practice, and it's not suggested to use them because of the preliminary nature of the data. So it's too early to tell if it really makes a difference. And that these tests kind of have lack of compelling evidence that they affect the outcomes in clinical practice. And that's basically what I've seen too, is I've run them and it tells you, okay, you're a good metabolizer of this, but not of this. And sometimes it ends up making you feel like you can't use a lot of drugs. And then if you just had tried, you might have had some good response anyway. So long story short, they haven't been shown to be very beneficial yet, but it's an emerging field in psychiatry for sure.
Overall, still very interesting.
Absolutely.
And I know we've probably mentioned the word side effects 30 times now in this episode already, but it's important because it is one of the main reasons that patients will avoid starting these medications in the first place.
Absolutely. So just a reminder again, for the most part, these medications are really well tolerated. The discontinuation rate of SSRI medications is actually much lower than the GLP-1 medications everyone's shelling out on every street corner right now, right? So in other words, these anti-anxiety, antidepressant drugs are tolerated better than all the weight loss diabetic injections being handed out right now. So, think about that when you're like, okay, well, I'm willing to, take a shot to lose weight. Well, would you be willing to take an SSRI to maybe help with those depression or anxiety symptoms that might be inhibiting you from wanting to go, make some of those changes and choices, right? The most frequent side effects, though, do include nausea. That's the most common. Some dry mouth, headache, insomnia, loose stools, diarrhea, sexual dysfunction, somnolence, so being kind of tired, sweating, tremor, and weight changes. And we will come back to some of those.
Yeah, especially the weight changes one. I feel like that comes up a lot. And, of course, those always sound lovely because anytime you read the side effects of any medication, that always sounds lovely. And no medication has 0 side effects. So keep that in mind as well. But most people don't get all of those.
No, most people don't get any of them. So remember, most people have minimal to 0 side effects at all. And we have to list all of those possible ones, which does make it sound worse than it usually is. And if you have side effects, there's ways around a lot of these.
Yeah, that's fair.
So while any SSRI can cause side effects, there are a few general trends in side effect frequency that can be noted. So nausea and sedation may be more common to occur with paroxetine and fluvoxamine. Diarrhea is more common with sertraline. Activation or feeling jittery may be more likely to occur with fluoxetine and sertraline. And then sexual dysfunction may be more likely with paroxetine. Weight gain and anticholinergic side effects like that dry mouth are most common with paroxetine. And if you went to med school, if you're a medical listener, you might remember that Paxil packs on the pounds. So that's paroxetine. That's how we always remember that one. Although side effects that occur at the onset of treatment can persist beyond 3 months of treatment, many are temporary and resolve. So meaning that you may have some symptoms for the first 3 months and if that. Usually the symptoms are a couple days, and most of them will resolve. So I often counsel patients that they may experience some nausea, some stomach upset, or jitteriness for the first 3 to 5 days, but these usually completely resolve if they can stick with the medication. If they don't, then we can reduce the dose to help alleviate the problem if that dose was titrated up, or change the medicine. Dividing the dose during the day also sometimes can help. I've had some patients that had some nausea on sertraline, so we did 25 milligrams in the morning and 25 in the evening for a 50 milligram starting dose, and they tolerated that great. So there's a couple tips and tricks. Again, the nausea, which is the most common side effect, is often the most distressing side effect, can be helped by starting the drug at a relatively low dose and taking the drug with food.
And I would mention that I've actually used these side effects to my benefit at some points. Like since some have constipation versus diarrhea as more of a side effect, I'll actually use them more selectively on patients who are suffering from the opposite.
Yes.
So it kind of tends to bring them back more to normal than to overshoot. So sometimes side effects are a good thing because it actually helps me treat more than one thing. But the side effects everyone always wants to talk about is weight gain. It's kind of like what you get with birth control as well. It's all everybody wants to talk about. And we have a lot of data about this. Use of SSRIs does have the potential to result in weight gain, but in some cases, it's actually not clear if it's really just the medication side effect versus the result of patients feeling better from depression and the reversal of undesired weight loss.
Yeah, so I have patients that have been severely underweight, and it was just because of all their anxiety that was going on, their depression. They were just not eating, and then they gain a little bit of weight, not too much, but just tiny bit enough that it helps them. And then I have patients who overeat when they're anxious, and they actually lose weight on their SSRI because they're not sitting there and binge eating or overeating or stress eating, and just they have this feeling of being more motivated and getting to the gym and making those decisions they need to.
Yeah, and your provider can look at specifically why they're starting it because there are differences in each SSRI and weight gain. So, each patient, like you mentioned, may benefit from it in different ways. Fluoxetine can lead to a small amount of weight change ranging from, a loss of 0.2% of body weight at baseline to a gain of up to 1%. A 1-year randomized trial shows that a mean weight gain was about 6 pounds for fluoxetine compared to 7 pounds for placebo, aka the placebo actually gained more weight. A similar study showed that sertraline had a potential weight gain of about 1% of body weight, but the placebo weight gained more. Paroxetine is the only SSRI with studies showing a more consistent weight gain ranging from 1.5 to 3.5% of body weight. For reference, that means if you weighed 150 pounds, that would be a weight gain of 2.5 to roughly 5 pounds. None of these studies show large amounts of weight gain as often as it is reported by social media. But of course, you want to talk to your doctor about any concerns to figure out which SSRI is best for you.
The other common concern about SSRIs is their effect on sexual dysfunction. So this is also an area with many myths floating around on social media. So we're here to tackle those.
So let's break it down. Depression and anxiety themselves can cause sexual dysfunction issues, in particular decreased libido, decreased frequency of sexual activity, and difficulty with arousal. SSRI sexual dysfunction is more commonly orgasmic difficulties. Studies have shown that sexual dysfunction described as decreased libido and arousal may be more from the depression itself than the SSRI side effect. All that being said, again, talk with your doctor before discontinuing the medication. Not only could the reported side effect not be from the medication, that may not even be the right issue, and also may just be changed to a different type of medication.
Ooh, we weren't kidding when we said we had a lot to cover as far as SSRI discussion goes. Let's switch gears to our Hollywood hype, though.
All right, great. You may have heard, and it's even on the cover of People magazine, unfortunately, Gene Hackman passed away tragically in his home. And it was a very confusing scenario there for a while because both him and his wife passed away, and they weren't really sure why because there was no obvious cause at first. And he actually ended up dying of natural causes described as cardiovascular disease and dementia. His wife, though, passed away tragically around the same time. I think they said about a week beforehand. And her cause of death was something that we don't see a lot.
So Betsy Arakawa, I'm going to make sure I say that right, died from uncommon infection called hantavirus. Hantaviruses are actually a family of viruses which can cause some serious illness and death. These viruses cause diseases like hantavirus pulmonary syndrome, HPS, and hemorrhagic fever with renal syndrome, HFRS. They are spread mainly by rodents and are not spread from person to person.
Yeah, again, not something we see very often. Hantavirus can infect and cause serious disease in people worldwide, but fortunately not something we see. People get hantavirus, as just mentioned, from contact with rodents like rats and mice, especially when they're exposed to their urine, their poop droppings, or their saliva. It can also spread through a bite or a scratch by a rodent, but that's pretty rare. And as Jess mentioned, the hantavirus causes two syndromes. That's kind of what causes the complications. And we mostly see it in the Western Hemisphere, including here in the US. And I think hantavirus pulmonary syndrome is kind of what we see more commonly than the other. And usually we see that spread by deer mouse. That's the most common rodent we see it with. Hemorrhagic fever with renal syndrome is a group of clinically similar illnesses caused by hantavirus, again, but that's mostly found in Europe and Asia. However, to mention the SEAL virus, I didn't say that right, SOL virus, a type of hantavirus that causes HFRS, is found worldwide, including the United States.
So hantavirus pulmonary syndrome is a severe and potentially deadly disease that affects the lungs. Symptoms usually start to show 1 to 8 weeks after contact with an infected rodent. Early symptoms can include things like fever, fatigue, muscle aches, especially in the large muscle groups like the thighs, hips, backs, and sometimes the shoulders. About half of all these patients experience headaches, dizziness, chills, abdominal pain, nausea, vomiting, diarrhea, things like that. 4 to 10 days after the initial phase of illness, the late symptoms appear, and these can include things like the shortness of breath, chest tightness, lungs filling with fluid, and it can actually be deadly. So this is what we're assuming is the hantavirus, since it's the only one in the United States we really trend there. 38% of people who develop respiratory symptoms may actually die from the disease, tragically.
And hemorrhagic fever with renal syndrome that we have mentioned is HFRS. I don't know why that's so hard to say. It's a severe and sometimes deadly disease as well that can affect the kidneys more so. Symptoms usually develop, again, within 1 to 2 weeks after exposure. In rare cases, you may see it up to 8 weeks later, but that's rare. Initial symptoms could include intense headaches, back and abdominal pain, fevers, chills, nausea, blurred visions. And these are somewhat generic. So you kind of have to have a high suspicion for this if you're seeing this as a provider. People may also complain of flushing of the face, inflammation of their eyes, or a rash. Later symptoms can include things like your blood pressure being low or, even internal bleeding, shock, acute kidney failure, those type of things. The severity of disease varies really depending on the virus causing the affection. I'm probably not saying that right, and Dubrava virus infections usually cause severe symptoms, with 5 to 15% of the cases being fatal. In contrast, the SOL, Sarama, and Pumala virus infections are usually more moderate, with less than maybe 1% dying from the disease. Complete recovery, though, can take several weeks to months.
There is no specific treatment for hantavirus infection, and really prevention is key, just reducing your risk by eliminating or minimizing contact with rodents in your home, workplace, or campsite. So patients should receive supportive care if they do have it, including rest, hydration, and treatment of symptoms. HPS can cause breathing difficulties, and patients may need to have breathing support, such as intubation, which is pretty scary. But intubation, if you know, is a medical procedure where the tube's placed in the lungs from the mouth to help the patient get oxygen. HFRS can disrupt the kidney function, and then you might have to have dialysis as well. So it's really not, this is not common. That's why we bring this up as being interesting.
Absolutely. And again, because it's not common, as a provider, you have to have a pretty high suspicion, especially if it's in the first 2 to 3 days of symptoms, because testing may not be as accurate. Symptoms could be vague, like fever, muscle aches, nausea, fatigue. Those can be confused with other diseases like flu, for example. So if you do suspect it, though, as a physician, make sure that you report that to the CDC. And as a patient, make sure you report to your provider if you have any potential rodent exposures that they need to know about. I did not know having hantavirus infection was going to be on my bingo card for 2025, but we talked about it here. So it makes for good education, that's for sure.
That's all for this episode of the MedEdit podcast. Don't forget, if you're a listener claiming CME credit, please look in the show notes for your instructions.
And for all of our listeners, thank you for tuning in. Please like, subscribe, follow us on socials, and share the episode. Let us know what other topics you're interested in through our Instagram and TikTok, and stay tuned for the next one.
Thank you for listening to the MedEdit podcast. Please click the follow button to be notified when more episodes become available. For more information about this episode and to find out how you can reach Dr. Cari Sorrell and Dr. Jessica Gray, please visit today's show notes. Be sure to follow us on our socials, Facebook, Instagram, and TikTok to stay up to date on all things the MedEdit podcast. The information and content has been made available for informational and educational purposes only and does not constitute a physician-patient relationship. If you need medical advice or help, please contact your personal physician. The views and opinions of the guests do not necessarily reflect the views of Dr. Jessica Gray or Dr. Cari Sorrell. This podcast should not be considered an alternative to medical advice or diagnosis or confirmation of an illness or disease. Please seek help from your personal care practitioner. Thank you for listening, and tune in next time.